Hello, this is Miss Page, and this lecture will cover congenital heart disorders. Congenital heart disease includes anatomic abnormalities present at birth that result in abnormal cardiac function. The incidence of CHD in children is approximately 8 to 12 per 1,000 live births. CHD is a major cause of death other than prematurity. The exact cause of most congenital cardiac defects is unknown, but most are thought to be a result of multiple factors, including genetic and environmental influences. Risk factors include maternal risk factors such as chronic illnesses like diabetes, alcohol consumption, increased maternal age, poor maternal nutrition, and exposure to environmental toxins and infections. A family history of a cardiac defect in a parent or sibling increases the likelihood of a cardiac anomaly. And Down syndrome or trisomy 21 and trisomies 13 and 18 are highly correlated with congenital heart defects. Prevention of congenital heart disease includes optimal nutrition, prenatal care, avoiding drugs and alcohol during pregnancy, immunizations, and recognizing signs and symptoms early. Before we talk about the different types of congenital heart disorders, we will review fetal circulation. So blood carrying oxygen and nutrients from the placenta enters the fetal system through the umbilicus via the large umbilical vein. Part of the blood enters the portal and hepatic circulation of the liver, and the remainder travels directly to the inferior vena cava by the way of the ductus venosus. Oxygenated blood enters the right atrium through the inferior vena cava, and because of the high pressure of the blood entering the right atrium, it is directed across the right atrium and through the foramen ovale to the left atrium. The foramen ovale is one way that fetal blood can bypass the lungs. There will be some blood that comes back through the pulmonary vein into the left atrium, and then through the left atrium to the left ventricle to be pumped through the aorta to the head and the upper extremities. Blood from the superior vena cava is directed downward through the tricuspid valve into the right ventricle. Blood in the right ventricle is pumped through the pulmonary artery, where the major portion is shunted to the descending aorta via the ductus arteriosus. Only a small amount flows to and from the non-functioning fetal lungs. Remember, they don't need a lot of oxygenated blood to the lungs because they are not using the lungs while they're in the womb. After birth, with the first breath, the lungs are expanded and oxygen causes pulmonary vasodilation. Normally, the foramen ovale closes as the pressure in the left atrium exceeds the pressure in the right atrium, and the ductus arteriosus starts to close in the presence of increased oxygen concentration in the blood and among other factors. And usually the ductus arteriosus will close within 10 to 15 hours after birth. There are different classifications of congenital heart defects. Increased pulmonary blood flow includes atrial septal defect, ventricular septal defect, patent ductus arteriosus, and atrioventricular canal defect. There is an abnormal connection between the high pressure left side to the low pressure right side that occurs, and it causes increased pulmonary blood flow. Signs and symptoms will most often show heart failure. Decreased pulmonary blood flow defects include Tetralogy of Fallot and Tricuspid atresia. There is some type of obstruction to the pulmonary blood flow from a connection between the right and the left sides of the heart. Blood has difficulty exiting the right side of the heart through the pulmonary artery, So the pressure on the right side exceeds pressure on the left, causing the desaturated blood on the right to shunt to the left, which causes desaturation of the left side blood, leading to desaturated systemic circulation. This causes hypoxemia and cyanosis because the blood that is being pumped out is not saturated enough. Obstruction to blood flow out of the heart includes coarctation of the aorta, aortic stenosis, and pulmonic stenosis. Blood exiting the heart meets an area of anatomic narrowing or stenosis, causing obstruction to blood flow, which causes pressure in the ventricle and the great artery before the obstruction to increase and the area beyond the obstruction to decrease. Obstruction on the left side of the heart results in heart failure because the blood is backing up into the lungs from the left atrium, and obstruction on the right side of the heart results in cyanosis because the blood is not getting to the lungs. Mixed blood flow includes transposition of the great arteries, total anomalous pulmonary venous return, truncus arteriosus, and hypoplastic left heart syndrome. The last three we won't cover, but know that they are types of congenital heart defects. What happens in mixed blood flow defects is fully saturated systemic blood flow mixes with desaturated pulmonary blood flow, causing a relative desaturation of the systemic blood flow. Pulmonary congestion occurs, cardiac output decreases, and signs of heart failure might show depending on how bad the mixture of the blood is. Depending on the amount of mixing and pulmonary blood flow, you can also see hypoxemia and heart failure, usually together. An atrial septal defect is an abnormal opening in the atrial septum, allowing blood from the high-pressure left atrium, or oxygenated blood, to flow in the low-pressure right atrium, deoxygenated blood. Signs and symptoms, they might be asymptomatic, and they may develop heart failure, depending on how large the defect is, and you might also hear a murmur. Treatment for this is going to be surgical correction. A ventricular septal defect is an abnormal opening in the ventricular septum, resulting in blood flow from high-pressure left ventricle, which has oxygenated blood, to shunt to the low-pressure right ventricle, which contains deoxygenated blood. The defect can vary from the size of a pinhole to no septum at all. Signs and symptoms, you might see a patient that is asymptomatic, or it could be to showing signs of heart failure. The increased pressure in the pulmonary artery from the right ventricle can lead to heart muscle hypertrophy, which decreases cardiac output and leads to heart failure. You might also hear a loud, harsh systolic murmur and palpable thrill. Treatment. Some of these VSDs can close spontaneously. Palliative treatment is a pulmonary artery banding where a band is placed around the main pulmonary artery to decrease pulmonary blood flow. And others might require open heart surgery using sutures to close the defect or a Dacron patch that is sewn over the opening. Patent ductus arteriosus is failure of the ductus arteriosus to close within the first weeks of life. Blood continues to flow from the aorta, which contains oxygenated blood, to the pulmonary artery, which contains deoxygenated blood. The excess blood is recirculated through the lungs and backs up into the left side of the heart, leading to an increased workload of the heart and pulmonary congestion. Signs and symptoms, the patient might be asymptomatic, or they can show signs of heart failure. You'll hear a machinery-like murmur, a widened pulse pressure, and bounding pulses. Treatment includes indomethacin. This was proved to be successful in closing the patent ductus arteriosus in preterm infants and some newborns. Surgical division or ligation of the vessel through a thoracotomy might also be used as treatment. They can also use clips through minimally invasive surgery, or coils to occlude the patent ductus arteriosus, and those will be placed in the cath lab. An atrioventricular canal defect is a large central opening between the two AV valves, which allows blood flow between all four chambers of the heart. This is the most common cardiac defect in children with Down syndrome. Signs and symptoms will include moderate to severe heart failure and mild cyanosis that increases with crying. Treatment: palliative treatment is pulmonary artery banding, and a complete repair includes sewing a patch over the opening. Tetralogy of Fallot is a type of decreased pulmonary blood flow defect. It includes 4 defects: pulmonary stenosis, ventricular septal defect, right ventricular hypertrophy, and an overriding aorta. Pulmonary stenosis increases the pressure in the right ventricle and decreases blood reaching the lungs to be oxygenated. Ventricular septal defect allows flow of blood from the left ventricle to the right ventricle, mixing oxygenated and deoxygenated blood. Right ventricular hypertrophy is an increase in the size of the muscle of the right ventricle, which decreases the effectiveness of the right ventricle in pumping. And an overriding aorta is when the aorta lies directly over the ventricular septal defect and receives mixed blood. Signs and symptoms include episodes of severe cyanosis and hypoxia. These are also known as blue spells or tet spells, that usually occur after crying or feeding when the infant's oxygen requirements exceed blood supply. You might also see clubbing of the nails, dyspnea, squatting, poor growth or mental slowness. And the reason that the child will assume a squatting position is this increases blood flow to the lungs and helps with the signs and symptoms of dyspnea. You might hear a systolic murmur. Treatment is a Blalock-Taussig shunt operation. This is palliative. It helps increase pulmonary blood flow, which increases oxygen saturation. There's also the complete repair, which includes closing the VSD, a pulmonic valvotomy, and repair of the overriding aorta. Tricuspid atresia is when the tricuspid valve fails to develop, so there's no connection from the right atrium to the right ventricle. Blood flows through an atrial septal defect or a patent foramen ovale and through a ventricular septal defect. There is complete mixing of unoxygenated and oxygenated blood, leading to systemic desaturation. Signs and symptoms will include cyanosis, tachycardia, and dyspnea. In older children, they might have signs of chronic hypoxemia with clubbing of the nails. Treatment is a shunt to increase blood flow to the lungs. Coarctation of the aorta is a type of obstruction to blood flow out of the heart defect. This is when there is a narrowing of the aorta near the insertion of the ductus arteriosus. It results in increased pressure proximal to the obstruction in the head and upper extremities, and decreased pressure distal to the obstruction, like the body and lower extremities. Signs and symptoms include a high blood pressure and bounding pulses in the upper extremities, with weak or absent femoral pulses and cool lower extremities. You might also see signs of heart failure, dizziness, headache, fainting, or epistaxis, and these patients are at risk for hypertension, a ruptured aorta, an aortic aneurysm, and stroke. Treatment includes enlarging the constricted segment with anastomosis. So essentially, they will take out this constricted part and suture it back together, or they can put a graft in there to help open that segment. A balloon angioplasty is often used for older children. Aortic stenosis is narrowing or stricture of the aortic valve. there is resistance to the ejection of blood from the left ventricle. This causes resistance to blood flow in the left ventricle, decreased cardiac output, left ventricular hypertrophy from the extra workload, and pulmonary vascular congestion from increased left atrial pressure, leading to increased pressure in the pulmonary veins. Signs and symptoms include decreased cardiac output, faint pulses, hypotension, tachycardia, poor feeding, exercise intolerance, chest pain, or dizziness when standing for a long period of time in older children. Treatment includes balloon dilation in the cath lab. This is usually the first line of treatment because it's minimally invasive. An aortic valvotomy can also be performed, and they might also need valve replacement. Pulmonic stenosis is narrowing at the entrance to the pulmonary artery. Resistance to blood flow causes the right ventricle to hypertrophy and decreases pulmonary blood flow. Signs and symptoms can be asymptomatic. They might show mild cyanosis or signs and symptoms of heart failure. The more narrow the stenosis is, the worse the symptoms are. You might also hear a murmur. Treatment for this is balloon angioplasty or valvotomy. Transposition of the great vessels is a type of mixed blood flow defect. This is when the pulmonary artery is connected to the left ventricle and the aorta is connected to the right ventricle, so the great vessels are switched. Signs and symptoms include cyanosis, cardiomegaly, and heart failure. Treatment will include IV prostaglandin E to keep the ductus arteriosus open until surgery can take place. The rash kind procedure, which is a balloon atrial septostomy to open the atrial septum and allow the blood to mix. And the arterial switch is the procedure of choice, which switches the aorta and the pulmonary artery. Assessment of a patient with a congenital heart defect will include history and objective signs. History includes prenatal history, so did the mother take prenatal vitamins, did she smoke or ingest alcohol during pregnancy? Ask about birth facts, what was the weight, height of the baby, and were they premature or full term? Also ask about family history of congenital heart disorders. Objectively, you'll check vital signs, heart rate, blood pressure, respiratory rate. A respiratory assessment, look for grunting, nasal flaring, or retractions. Listen to heart sounds, check peripheral pulses, look at skin color, especially looking for cyanosis, check for clubbing of the nails, and check the weight of the patient. Also, monitor to see if the child is in a squatting position. Again, children will squat when they are short of breath because it's thought to help increase peripheral vascular resistance, which in turn pushes more blood flow to the lungs. The exact mechanism of how this works is still unclear, but squatting position is common in Tetralogy of Fallot patients. Diagnostic tests include an EKG to check for dysrhythmias. A chest X-ray will show information on the heart size and pulmonary blood flow patterns. A cardiac MRI shows vascular anatomy outside of the heart and ventricular mass and volume. An echocardiography shows images of the cardiac structures. A cardiac catheterization. This can be diagnostic or it can also be therapeutic. An exercise stress test will monitor heart rate, blood pressure, EKG, and oxygen consumption at rest and during exercise. And blood tests like ABGs or CBCs are also commonly done. Nursing interventions include monitoring, educating, and assessing the psychosocial concerns of the family. Monitor I's and O's, check for weight gain, and monitor oxygen saturation. Keep the child in a semi to high Fowler's position to help ease breathing, or help them to a knee to chest or squatting position during episodes of dyspnea. Educate the parents and the child on routine health care, medications, activity levels, signs and symptoms, the disease process, and tests and procedures that they might come into contact with. Educate them to conserve energy and help schedule rest periods, and also provide quiet activities in the bed that the child can do, like playing on their iPad, coloring. Psychosocial, you want to assess the emotional concerns of the family, answer questions, and refer them to support groups. Heart failure is the most common complication of congenital heart disease because of structural abnormalities. These abnormalities result in increased blood volume and pressure within the heart. The heart is unable to maintain adequate cardiac output. Decreased blood flow to the kidneys will stimulate sodium and water reabsorption, which leads to fluid overload, increased workload on the heart, and congestion in the pulmonary and systemic circulation. Signs and symptoms of heart failure can be split into 3 groups: impaired myocardial function, pulmonary congestion, and systemic venous congestion. With impaired myocardial function, you might see tachycardia, sweating, decreased urine output, fatigue, weakness, restlessness, anorexia, pale, cool extremities, weak peripheral pulses, decreased blood pressure, and cardiomegaly. Pulmonary congestion, you might see tachypnea, dyspnea, retractions, nasal flaring, activity intolerance, especially with feeding, orthopnea, cough, hoarseness, cyanosis, wheezing, or grunting. And with systemic venous congestion, you'll see weight gain, hepatomegaly, peripheral edema, ascites, and neck vein distension. Treatment for heart failure includes improving cardiac function, removing accumulated fluid and sodium, decreasing cardiac demands, and improving tissue oxygenation. Cardiac function can be improved through the use of digoxin, ACE inhibitors, and beta blockers. Digoxin improves contractility. You want to make sure to monitor for digitalis toxicity. Check the apical pulse prior to administration of digoxin, and teach the parents about digoxin and the signs and symptoms of toxicity, such as nausea, vomiting, anorexia, and bradycardia. ACE inhibitors are used to reduce afterload and make it easier for the heart to pump. Make sure to monitor blood pressure and renal function. And beta blockers are used to decrease heart rate and decrease blood pressure. Removing accumulated fluid and sodium is achieved through diuretics and fluid and sodium restriction. When using diuretics, administering diuretics, monitor eyes and nose, body weight, electrolytes, and make sure to give diuretics early in the day so that the patient is not up during the night using the restroom. Fluid restriction allow for most of the fluids during waking hours, and for sodium restriction, discuss foods that have sodium in them with the family and patient, and educate them on avoiding these foods. Decrease cardiac demands by preventing cold stress by keeping the environment warm. Treat existing infections. Reduce effort of breathing by putting the patient in a semi-Fowler's position and feeding them in a semi-Fowler's position. Encourage the parents to stay and hold the child to help them sleep. Provide for rest and decreased environmental stimuli. Feed the child at the first sign of hunger, like when they suck on their fingers, rather than waiting until they start crying. And offer small feedings to prevent tiring. Usually they are on a 3-hour feeding schedule. Improve tissue oxygenation and decrease oxygen consumption by providing a cool humidified oxygen with an oxygen hood, nasal cannula, or face tent, and educate the patient and family to avoid family members or visitors with respiratory infections because the respiratory tract infections can exacerbate heart failure. That is all I have for congenital heart disorders. If you all have any questions, please Email me or message me on Teams, and I look forward to seeing you all at the Q&A.